Oh,
This
hey.
this is our schedule.
Cool.
I highlighted the ones that we may not be here for.
Okay. Yeah, I figured before break.
Yep,
Yeah, you and baseball, just
right.
way you go. Wow. Starts soon, doesn't it? Okay. You guys gonna be ready?
Hopefully.
Okay.
Hopefully, people that are injured come back.
Yeah. How's your pitching?
Good. We've been pitching this year.
Okay. I know you guys had some injuries pitching.
Yeah, we lost our catchers.
Oh, that's not good.
Yeah, we.
That's not good.
Retreat.
That you need a good catcher. Did you guys bring either calculators with you or do you have calculators on your phone? You'll need a calculator unless you're really good at doing long division in your head. So you can use your phone calculator. And this is provided for your use. Where's Bracken? Oh, there, okay. Spoke too soon. It's cold out there. Oh, man. It hurts. Your cheeks are all red. We can, sure. So in order for something to have the ability to have different stereoisomers, you have to have a carbon-carbon. You have to have a carbon to which 4 different constituents are attached. So we have, for example, this molecule, if we take this molecule and we add, say, another hydrogen over here or something like that, or well, we take this off, we add 2, we add, instead of all this, we just add a hydrogen. Then you have 2 constituents that are the same. So this is not capable of having any stereoisomers. This, however, has a hydrogen, nitrogen, and then 2 carbons, both of which have different constituencies attached to them. So this is capable of having different stereoisomers. And the number of stereoisomers that it can have is 2 raised to the power of the number of carbon-carbons. So this is 1 carbon-carbon. So it's 2 raised to the power of 1 or 2. So there's 2 in the R and S. So you take the constituents and then you go over to your friend here, the periodic table, and you ask which one is the biggest on the periodic table. So hydrogen is going to lose every time because hydrogen is number 1. So hydrogen, that's That's your lowest on the totem pole of constituencies. So here's nitrogen, here's carbon. Where's nitrogen and carbon? Well, there's carbon, there's nitrogen, so nitrogen wins. Now, if you have oxygen, oxygen is going to win. And then anything bigger than that, of course, is going to win. So nitrogen is the one that wins here. So that's number one, that's number four. So the question now comes, these two. Which one's two, which one's three? So this carbon has two oxygens attached to it. This carbon has one oxygen attached to it and then a carbon. So oxygen beats carbon, doesn't it? So two oxygen is going to be a carbon with one oxygen. So that wins. So you hold the lowest constituency away from you. That's one, that's two, that's three. And does that go the way of the clock, or does that go opposite the way of the clock? Goes the way of the clock, it's the right way. If it goes opposite the way of the clock, it's a stupid way. Yes, it goes the way of the clock. So that's basically stereochemistry. And again, works best if you make them all. Don't make them all. Well, you have to do it in your head. So, and again, these are 4D molecules. These 4D molecules, you have to remember, carbon makes a tetrahedron. So you imagine this has the 1, 2, 3, 4 different constituencies. So that's why essentially, even though you draw it as a 2D molecule, you think it's a 3D molecule. Very often when this is written on a sheet of paper, you'll have things that look like this. Something like that. If the wedge is filled in, that is meant to represent a 3D structure where the constituency is coming at you. So that would mean essentially that the methyl group essentially is pointing at you. If you see a wedgie that looks like this, that means it's pointing away from you. And then very often, you will see structures that and you'll notice there's no hydrogen there. Well, carbon has 4 bonds to it. So by convention, it's understood there's a hydrogen and it's on the other side. It's sticking out away from you. So essentially they've done the stereochemical work for you. Because it's pointing away from you, so now that's why essentially they write it that way. So you just now just take it, or you just go, oh, oxygen, carbon, okay, it becomes a lot easier then. So that's why some people, when they see things that look like that, they say, well, where's the hydrogen? It's by convention, it's understood to be there because it's understood that carbon has 4 bonds to it. So there is a hydrogen and it's not listed. Now, if you have something other than a hydrogen, you have to list it. But if it's not listed, then you can readily assume it's hydrogen. That's just some chemical convention stuff to be aware of. That help? Okay. Normally I go over the quiz, but since we have people who will take it on Monday and who are probably listening via Zoom, we can't really do that. So, all right. Now, Mrs. Schaefer has told me that many of you have not purchased the notes that are bound together. We still have a lot of copies left in the office, so please pick those up. Just go see her and give her a deposit for it. And you can get all the notes, all the handouts essentially. That's what that is all the handouts essentially pieced together. And I don't know if many of you know Brianna Mead, who has joined our class. She comes to us from the nursing program, and she has decided that she'd rather be a physical therapist. So welcome, Bree. We're very glad you're here. And we apologize for having to get up at this hour. You think it's better? Okay. Yeah, better than night class. So where everybody's tired and having to wake each other up. All right. So we talked last time about this concept of half-life. That's the time it takes beginning when you initially dose the drug by whatever means. The time from when you dose the drug to the time it takes to reduce the amount of the drug that it achieves at its peak to be decreased by half. The time, starting from when you dose it, that it takes to reduce the amount of the drug in the circulation by half. After you take it, the drug will peak. The time it takes to reduce that peak to half in the circulation. That's the half-life. Some drugs have very long half-lives. Others have really short half-lives. Drugs with very short half-lives, either you have to dose them at levels where it doesn't matter if the amount decreases because you still get good therapeutic results. Others, you just have to dose often. Yeah. No, well, it can. If it's renally excreted and it ends up in blood at high levels and it's very effectively excreted by the kidney, and especially if it gets trapped in the urine, so it doesn't get reabsorbed, then it can, sure. So yeah, that can influence it, definitely. So from the handout that you have on this, so you have a series of equations that are on there it is, page 9. You have a series of equations essentially that provide you ways to essentially calculate different types of pharmacokinetic parameters. Half-life, as you can see, is at the bottom of that table, and it says here. So it's 0.693 divided by the elimination rate. That would be clearance, and that'd be clearance, that'd be the addition, the sum of clearance by any means. That'd be the total clearance. That would be how you would calculate the drug half-life. And so, Bracken, that kind of gets to your question. If your clearance is high because it's being trapped in the urine, or is being trapped in bile, or is being trapped wherever and then getting excreted and then not getting reabsorbed, then sure, the bigger that number is, the lower your half-life is going to be, isn't it? Let's illustrate half-life by using a drug that you would administer intravenously. So if you administer someone a drug intravenously, it'll take time for that drug to accumulate. There will come a time, however, after which you can give a person the same amount of the drug, but the concentration in the bloodstream is not going to go up. Because at this point, the rate at which you're introducing the drug and the rate at which it's being eliminated is the same. So this is called a steady state. steady state infusion of the drug at this point. So it accumulates at a peak. You're keeping it at that peak because you keep administrating it. What happens if you remove the IV, turn off the infusion pump, whatever? This is what happens. Now the drug will fall from its peak to this level where it eventually goes to 0. Notice the time at which those two graphs cross. That gives you a particular time, and that particular time is defined as the half-life. Notice it gets to about 50% total plasma concentration. So that's the time it took when the drug was at its peak to the time it was reduced by half. That's a half-life. So a rule of thumb with constant infusions goes something like this. It will take you about 4.5 half-lives to achieve maximum effect, which you kind of sort of see here with this graph. You get to maximum really round about here, which is about 4.5 half-lives, gives or take a half-life or a half-life or something like that. So that's your rule of thumb, about 4 to 4.5 half-lives to achieve maximum effect. Now this leads us to another pharmacokinetic parameter called bioavailability. You'll notice on page 9, there is an equation also for bioavailability. I would invite you to take a look at that. Oh, also, this particular graph here is recapitulated here, and it shows you essentially what that looks like. So essentially, for theophylline, as you can see here, where these two graphs cross, pretty much is 8 hours. So that tells you the half-life of theophylline, at least intravenous theophylline, is 8 hours, as illustrated in this graph here. So bioavailability refers to the percentage, the decimal fraction of the drug that gets into the systemic circulation. That's after you administer it by any route. If that particular drug reaches the circulation and it's been metabolized into a metabolite that's not active, you don't count it. So this will always be a percentage. This will always be a number less than 1. The closer this number is to 1, the better the bioavailability. Now think about this with me. If you administer a drug intravenously, what percentage of that drug reaches the circulation? 100%, by definition. So by definition, the bioavailability of intravenous drugs will always be 1, will always be 100%. And all the others will be usually either close to 1 or will be below 1. Now you can see in this table, when it comes to drugs that are administered intramuscularly or drugs that are administered subcutaneously, your bioavailability is still pretty high. And the lower limit there is about 75%. When you administer a drug subcutaneously, to just review subcutaneous, so if you take your skin and just pinch it and then move it back and forth, that little platform upon which the skin moves, that's your subcutaneous skin. There's a little layer of fat, in my case, a rather large layer of fat underneath there. That area is very heavily vascularized. If you lay a bullet, in fact, that's how you give a sub-Q injection. You just pinch the skin. In fact, the nursing students are actually taught, because they have to self-teach, they have to teach patients to give their own sub-Q injections in some cases, people with rheumatoid arthritis, people with diabetes, things like that.
You pinch the skin and you insert the needle in there. You pinch and then put it in essentially, and you put in the bolus. And because that area is so highly vascularized, the uptake is very good. Intramuscular injections, you tend to give a depot of drug within the muscle. You want to pick a big muscle. So for vaccines, it's a deltoid. For when I was a kid, we used to get penicillin G shots. It's not done so much anymore, but you used to get that in your glute, essentially. Epinephrine, if someone has an allergy and they need epinephrine, where does an epinephrine shot go? Anybody know? Yep, quad. Goes in the quad. You get released pretty quickly and you have a depot of drug. Unfortunately, the half-life of epinephrine is very short, but you have a depot of drug now to prevent you from having further anaphylactic reactions. So those two modes of administration with a needle, and we call any type of administration with a needle, we call those collectively parenteral. So parenteral administration, as a rule, will have relatively high bioavailability. Now below that, you see oral. Tell me what you see when it comes to the bioavailability of oral drugs. Varies, and it varies wildly. Most of the drugs that are administered are oral because it's convenient. It's much more convenient to swallow a tablet than to give yourself a shot, right? So most drug formulations are oral. That's also one of the toughest formulations to make because you have to pellet it. You have to put it in a tablet now that'll hold together. If you put it in a capsule, you have to make sure that it dissolves properly with the gel cap and so on and so forth, what have you. Some drugs orally administered are extremely well absorbed and show very high bioavailability. There's a group of antibiotics, for example, called fluoroquinolones. They're very wide spectrum. They have almost 100% bioavailability. Very, very, very highly effective when it comes to their absorption and distribution into the blood. Oral morphine, not very good bioavailability. There's another opiate called meperidine. Trade name is Demerol. That one is not well absorbed at all. Maybe 35% of the drug is absorbed. So that one is going to be more on the lower end. So this one varies, and it varies pretty wildly. Rectal administration, and with this, you could also say vaginal, because some suppositories are vaginal. These areas are also very highly vascularized. The suppository tends to be encased in wax. The wax will tend to dissolve, and then the drug will be taken up, and the wax usually acts as a vehicle for the absorption of the drug. The reason this shows variable bioavailability is that if you put something in the rectum, what usually happens in the rectum? Things move through it, right? So you put a suppository in there, it's not necessarily going to stay there, is it? It's going to move out next time you have a bowel movement. Same thing with a vaginal suppository. The birth canal is not a static canal, is it? Things pass through it to try and be tasteful about it. So that's why you see this low end here, because something put there doesn't necessarily stay there. Having said that, it's a very convenient way to administer drugs to people, for example, who are unconscious. For babies, for example, aspirin comes as a suppository, and rectal uptake in infants is very high, very high. So that's why rectal / vaginal shows that lower end. Usually the uptake is very good. Inhalation, you see, has a very low bottom end because with inhaled drugs, very often the drug will end up at the back of your throat. That's where most of it ends up if you take it via an inhaler. The exception is with your inhaled anesthetics. So your volatile anesthetics typically don't end up on the back of the throat. They usually end up in the lungs and get absorbed very effectively. Also, any of the volatile anesthetic that does end up in the back of your throat usually gets absorbed because it's absorbed. They're small molecules. They're absorbed extremely well, regardless of where they end up. And they're also not a mist. They are a true gas. Other types of inhaled drugs that you take via a nebulizer. Have any of you seen a nebulizer? They're about this big, and the drug comes in a plastic container like that. You break the top off. Some people don't do that. Don't do that. You then put it usually in, and then it heats the drug, and then it makes a mist out of it. And you essentially, there's a mouthpiece. You put your mouth on it, and then you just breathe regularly, and you breathe in the mist. It's for people with typically really severe asthma. Does that ring a bell for any of you? Okay, I see somebody. Have you ever used one? You have one. Can you bring it in sometime? Yeah, bring it in sometime. That way we can all see it. Do you have the vials, the drugs? Bring those in too. That way we can see essentially. Not trying to put you on the spot. I'm sorry if that embarrasses you, but not everyone knows what a nebulizer is, but they're a very effective way to administer certain drugs. Just with inhalation, remember, there's an issue with the drug ending up in the back of your throat. Does yours come with a spacer? If you don't know what it is, then it probably doesn't come with a spacer. Spacers, many of the metered dose inhalers come with this thing called a spacer. And those spacers, actually, you get more of the drug in your lung if you use a spacer. The issue with spacers, you have to clean them. Otherwise, they grow things. I'll see if I can get I'll go across the street, see if they have a spacer. I can show you guys when we get to inhaled drugs. Transdermal is very effective. Transdermal is very effective because the drug has a vehicle, and that vehicle causes drug to pass through the skin very, very easily. The release is slow, so you can wear the patch for a long period of time. The issue with transdermal patches is that, number one, you never use a transdermal patch on a baby. Anyone know why? There you go. How thick is the skin on a baby? Thin, really thin. You way too much drug too fast, you poison the baby. Secondly, if someone uses a transdermal patch, you never take the patch off and throw it in the trash can because the patches are sticky and they got this mushy stuff on them. And what do kids like to play with? Stuff that's sticky, that's mushy stuff. So kids will get in the trash can and go, ooh, ooh, this is cool. And the opiate fentanyl is most popularly given as a patch. Kids have died playing with fentanyl patches in the trash. So you're supposed to take the patch off, seal it, put it together, and then flush it. So don't ever throw a patch. In fact, if you have patients, clients who have patches, train them that way. Third thing with a patch, don't put a heating pad on a patch. The heat will cause the drug to be released more quickly. You'll poison yourself. Same thing with exertion. If you have a patient or client who's an athlete, and they're using heavy sweat clothes over a patch, the patch is going to get overheated and it's going to release too much patch. They should probably, do it so that, wear something so that the patch is exposed, maybe. Working out in the winter, of course, is going to be a challenge for something like that. In which case, maybe they should work out, then put the patch on. That can also putting, if you're cold and say you sit on the vent or something like that, having a patch on next to the vent, that can increase the release of drugs. So that is a precaution with transdermal patches. For a drug to be made in a transdermal form, it has to be solubilized in a vehicle. Not all drugs can do that, but the ones that can, they're very effectively administered this way. So methylphenidate, which is given for ADHD, attention deficit hyperactivity disorder, that comes as a patch. The trade name is Detrana. Fentanyl, of course, comes as a patch. And then there's an anti-Parkinson's drug called saligeline that also comes as a patch, which is better tolerated as a patch than it is orally. And there are other drugs too that comes as patches, but those are just three that I can think of off the top of my head. So your bottom line here, this is the cat's wow for all this, is bioavailabilities are going to be determined by the way they're administered. And some of those modes of administration will bypass something called the first pass effect that we'll get to very quickly. So bioavailability depends, of course, on the extent of absorption. It depends also on the rate of absorption. If a drug is absorbed very slowly, then while the drug is absorbed, you're going to start to get rid of it. So that will affect bioavailability. Some drugs, if they are metabolized by the liver, are going to be affected by rate of blood flow through the liver. And if the drug is cleared by the liver, there is this equation that calculates something called the extraction ratio. The extraction ratio. Blood flow through the liver varies from person to person, also varies from male to female. So the rough average, statistical average for hepatic blood flow there is 90 liters per hour. That's going to differ from person to person. It also is lower for older people. Keep that in mind. You can look up in tables what that number might do. It also will vary if someone has liver disease. So extraction ratios are going to vary. Extraction ratios will affect bioavailability of drugs, especially if they are eliminated by the liver. Now, if a drug is taken orally, please remember that from the GI tract, the blood that drains the GI tract, the first stop for that blood is the liver. So some drugs, if they're taken orally, before they ever get to the systemic circulation, they go through the liver, and the liver will start to break them down. Some drugs experience extensive breakdown before they ever get to the systemic circulation. This is called the first pass effect. And the first pass effect can greatly reduce the bioavailability of certain oral drugs. Now, the way drug companies get around this is that they make the oral form of the drug as an inactive derivative that becomes activated by the liver when it passes through the liver. This type of formulation is called a prodrug. So that once it's absorbed, it goes to the liver, it's subject to the first pass effect, but that first pass effect actually activates it rather than inactivates it. Pretty ingenious when you think of it. So there are several drugs that are subject to very, very strong first pass effects. One of the most classic examples is morphine. One of the reasons why morphine usually isn't given orally, it tends to be given parenterally, because it's subject to the first pass effect. And it's also the reason why morphine is available in oral forms like codeine. So a drug like codeine is a prodrug. Codeine goes through the liver and it's activated into morphine. So that's why you usually don't give oral morphine, you give oral codeine. Intravenous doses, as you can see, simply pass go, collect $200 and go straight into the systemic circulation. If we consider some of the other modes of administration, and you have on your in your notes, there is a little table of various modes of drug administration on page 6. So if you have that with you, you might want to take a look at that. You can get these in the office. So Mr. Schaefer will find these out. Look at that first mode of administration, sublingual, under the tongue. Is that going to avoid the first pass effect? Sure it is. Sure it is. The tongue, the tissue underneath the tongue is very highly vascularized. The problem is finding a formulation of the drug that dissolves easily. And the drug has to be a small enough molecule to be able to diffuse through the mucosa of the mouth. Drugs, of course, like sublingual nitroglycerin do that very, very well. Because nitroglycerin is a very small molecule. As we go down, we see the rectal mode of administration. There is a rectal form of diazepam. Trade name of that drug is Valium. Diazepam is a very good anti-seizure drug. And if you have someone with status epilepticus, that is, they are constantly having seizures, you can't really give them something oral, can you? They'll choke on it. If you put a needle in their arm and they're seizing, is that optimal? No. So there is a rectal form of diazepam that will prevent their seizures. Will that avoid the first pass effect? Okay, yeah, Maddie's right. Yeah, it will. It will. So some of these modes will avoid the first pass effect. Now, some of these modes of administration are not systemic. For example, you'll notice there is ocular and oral administration, administration into the eye, administration into the ear. Are you going to get very good systemic circulation from administering something into your ear? No. That's for earaches, ear infections, things you get earwax out, stuff like that. Ocular, you'll get a little bit of systemic distribution, but it's not optimal for sure. So administration in the eyes usually is for eye problems, things like that. So some drugs are converted into metabolites, byproducts. Some of those metabolites have no activity. Others do have activity. And then some actually have side effects. Brecken? Not necessarily. Not necessarily, no. Liquid forms of drugs are usually because getting the drug to pellet is extremely hard, or the drug is indicated for populations who don't have the ability to easily swallow tablets. If you have someone who's had a stroke and swallowing, they can swallow soft foods, but not hard foods. then you want to either make a pill that can be easily ground up and put into applesauce or something like that, or yogurt, or kids who can't, young kids with ear infections who can't swallow tablets. So amoxicillin, for example, comes in lots of different liquid formulations. They're even flavored, for goodness sakes. You can buy grape and strawberry and orange amoxicillin nowadays. Heck, I wanted it last time I was sick. Because now there's a form of amoxicillin, I think is a dissolvable tablet that's flavored. It's like a Starburst almost. I mean, how cool is that? Well, yeah. So anyway, but that's for the kids so that the kids actually will want to take the medication. So pretty ingenious, but that is a product that can be put either in a liquid or into a tablet. Other products just don't pellet. For example, there's a antibiotic for urinary tract infections called fosfomycin. Getting that stuff to tablet is pretty near impossible. So it's just sold as a powder. And it comes as a powder, usually with a diluent. You just mix them together, shake it up, and then bottoms up, and that's how you take it. And the bioavailability of that product is not influenced by the fact that it's a powder. Not at all. So it is, however, influenced by the fact that it's an oral product that's administered orally. All right, so just keep in mind some drugs will have active metabolites. For example, the antidepressant venlafaxine. Venlafaxine is converted into desvenlafaxine, and desvenlafaxine and venlafaxine both have activity. And desvenlafaxine has more activity than venlafaxine. So some would call venlafaxine a prodrug, except that venlafaxine itself has activity. The trade name of venlafaxine is Effexor. Effexor. That's a drug that gets given a lot to veterans who have PTSD. All right, so drugs with high extraction ratios will vary in their bioavailability because liver activity and liver blood flow will vary from person to person. That's something to keep in mind. And when it comes to the physiological effect of the drug and the drug concentration, you might expect to see a nice straight line, but it's usually not linear. And I'll give you an example with this particular drug. This is a antihypertensive called enalapril. It is an ACE inhibitor, so it inhibits an enzyme called angiotensin converting enzyme. So let's think of a bread truck driver, and let's name this bread truck driver Eric. So Eric has idiopathic essential hypertension. What does idiopathic mean? Anybody know? Right. The cause is not determined. The cause cannot be effectively determined, idiopathic. So essential idiopathic hypertension, he takes enalapril. He takes 10 mgs. And this drug, the advice you'll always give with this drug is take it at the same time every day. So Eric gets up. He's got early rounds because the bakeries and the delis, they need their bread. So he has to get up really early. So he gets up at 4 o'clock because he has to be on the road by 5 to make his deliveries by 6. So he gets up at 4 o'clock and he eats his breakfast. And with his breakfast, he takes his enalapril every day, like clockwork. Even when he doesn't have to work, his body just wakes him up at 4 and he takes his enalapril. He's the kind of patient you'll want to see walk through your door. So he takes it and he gets this degree of enalapril essentially, and he gets that percentage of concentration in the drug. Enalapril is very effectively absorbed. And then as time goes on, as he drives his routes, eats his lunch, gets home to his family, so on and so forth, goes to bed. By the time he's ready to wake up and do it all over again, notice the percentage of inhibition of the enzyme is about 33%. Here's the drug concentration over time. So he takes it. Here, there's a lag because the drug needs to be absorbed. We get the peak going up there. When we get the peak, we get the peak inhibition of the enzyme, and then the drug starts to get metabolized, eventually going to about 0 at 24 hours. When he takes it again, it'll jerk back up there, go back down. But notice that even as the drug is decreasing, his inhibition of the target is still pretty good, isn't it? Because this is an irreversible inhibitor. So cells need to remake the enzyme. That's why he gets such good inhibition, even though the concentration of the drug is still decreasing. So even 3 hours after the dose, you still have the peak plasma concentration. You have about 7.5 half-lives that have elapsed from the time of the peak concentration to the end of the dosing interval. And during that time, your inhibition of the target is still 33%. That's because the EC50 of the drug is so low. It's 1 nanogram per mil. 1 nanogram per mil, essentially. That's a pretty low EC50. That's why the drug essentially works this well, even though it decreases so much. And the fact that you can dose it up as much as you do, and you don't have to continually dose it through the day, is a testimony to how safe of a drug this is. So the plasma concentration decreases some 16-fold after the first 16 hours, but the inhibition of the target only drops by 20%. That's why, even though this drug has a short half-life, you don't need to keep redosing it through the day. Now, you can also see why you need to take the drug at the same time each day, don't you? Because at the end of the dosing period, you take it again. Now it overlaps, you get consistent inhibition of the target. You get consistent control of blood pressure. Some drugs will have a lag time before they start to act. For example, there's a group of antidepressants called SSRIs, selective serotonin reuptake inhibitors. Selective serotonin reuptake inhibitors, you have to be on them for about 4 to 5 weeks before they start to kick in. Reason for that is that they need to change the expression in neurons of a particular serotonergic receptor before they actually start to show their therapeutic effect. A lot of patients start on those drugs and they say, it doesn't work. So they stop taking it after 3 weeks. Well, you have to give it 4 to 5 weeks before you'd actually see it start to work. Some drugs essentially need turnover of some sort of enzyme receptor, something like that, in order to start working. Clotting enzymes work this way. Anticoagulants might work this way. Some drugs need to build up in concentration before they'll have their therapeutic effect. Cancer drugs are a notorious example of drugs that need to have a certain concentration before they work. Some drugs, if they build up, they'll show certain side effects. And the example here is a renal toxicity of a group of antibiotics called aminoglycosides. There are other side effects too of certain drugs that are dose dependent. There's an antipsychotic called ziprasidone. Trade name is Geodon. This drug can cause arrhythmias of the heart, but those arrhythmias are clearly dose dependent. So if the drug starts to build up in the body, then you can start to get the arrhythmias. At standard doses, usually you don't get much arrhythmia. unless you're on another drug that also causes arrhythmias. So the dose that you give someone in order to maintain a steady state concentration in the body and average concentration, average steady state concentration in the body, that's called the maintenance dose. Maintenance dose. We can illustrate that essentially with this graph, and this graph is well, no, it's not, but anyway. So this essentially is for this anti-asthma medicine, theophylline. So here is an example of maintenance doses with 3 different modes of administration. So if someone comes in and they have really awful asthma, they've had an asthma attack, their airways are absolutely cinched down, they cannot breathe, and they get intravenous theophylline, that intravenous theophylline will be infused at a rate of 28 milligrams per hour. That will give you a steady state concentration of 10 milligrams per liter over this unit time. So that's your maintenance dose for that. 28 mg per hour for your intravenous dose gives you this plasma concentration of 10 mg per mil. So they're better, they're going to go home. You don't want to send them home with an IV that they essentially throw over their shoulder. Is that practical? No. You want to give them an oral dose of theophylline. You want to maintain that same average steady state concentration of 10 mg per mil. You want to dose them once a day, 24-hour administration. Your peaks and your troughs are greater in this case, but your average concentration of theophylline is still going to be 10 mg per mil. This only requires them to take the drug once a day. If you don't like those high points there because the theophylline concentration is too high at the peaks, you can give them an 8-hour administration. They have to take the medication 3 times a day. And now this gives you more peaks and troughs, but the range is not nearly as great as with the 24-hour dosing. The thing I want you to see with each of these is that even with these 3 modes of administration, your steady state or average concentration in the body stays the same. And if you look at this and you figure kind of an average concentration, it still stays as about 10 mg per liter. Even with those 3 different modes of administration. So how do you calculate essentially a proper maintenance dose, dosing rate, things like that? And this again, you have to use the equations that are on page 9, but this is how you're going to apply them. The dosing rate is going to be the clearance rate times the target concentration. The target concentration in this case being the 10 mg per liter. And then your dosing rate, which you calculate essentially with this equation, times the dosing interval, that gives you the maintenance dose. So here's a sample calculation. We'll use theophylline again for example. So our target concentration of theophylline is 10 mg per liter. That's a very well worked out number that is in the tables. You have some tables in your notes. They start on page 10. They go to page 12. And these are some of the pharmacokinetic parameters for some of these drugs, where you have the oral availability, that's essentially the bioavailability.
percent excreted, percent bound in plasma by proteins in the plasma, clearance rate, volume of distribution, half-life, target concentrations, and for those that are known here, essentially. So for this one, for theophylline, we have our target concentration. The mean clearance of theophylline is this number here. It's given intravenously, so our bioavailability is 1, so we don't have to worry about that. So to get the dosing rate, you will take clearance, multiply it by the target concentration. So you take those two numbers. Notice that liters is going to cancel. So you're going to milligrams per hour per kilogram body weight. 70 is kind of a rough average, but there you are. And then your dosing rate equals the infusion rate for intravenously administered drugs. And yeah, there's your number, 28 milligrams per hour. 28 milligrams per hour. Gee, look, that was our infusion rate. We didn't just pull that number out of the clouds. That number was calculated using these pharmacokinetic parameters. Oh, okay. Now the dude leaves the hospital. We want to give the person oral theophylline. Now we have maintenance dose equals dosing rate divided by bioavailability times the dosing interval. The bioavailability for oral theophylline is 0.96. Very good. Not 100%, but pretty good. And if you want to dose them twice a day, essentially, you give them 350 mgs that they take twice a day. What will it be for an 8-hour dose or a 24-hour dose? You try it. Here's how you calculate it. Go ahead, pull out your phone or calculator or whatever, punch it up and tell me what you get for 8 hours. $40? $28 times 8. That sounds more like it. Oh, okay. Okay, yeah. 28 be divided by 0.96, which will be a little more than 28, not much more. About 233. Then for 24 hours, you just put in 24 and you should get a number something like 700 or something like that or what have you. So, all right. So that finishes it. We'll start on Monday talking about loading doses. We'll go from here into the biotransformation. And then we will go from biotransformation into drug-drug interactions. And then from there, we'll talk about medicines for the heart.